This is really more of a personal journey for me. It's actually become a bit of an obsession of mine to minimize the use of ionizing radiation in our endoscopy unit. So I want to say a few words about ionizing radiation, and then we'll talk about EUS-guided non-radiation ERCP and my personal journey with that. And then finally, this is where I think the next frontier is. It has been, but it's been very slow to evolve, but I think we're going to see very rapid progression in this space now, thanks to novel technology and more affordable technology, which is ductoscopy-guided non-radiation ERCP. The WHO categorizes ionizing radiation as a carcinogen. You know, we call it fluoroscopy. That's kind of a neutral word. It doesn't sound very threatening, does it? But as soon as we start saying ionizing radiation, well, there we become a little bit more nervous about the potential threat. And there is a threat. There is a 10% increased risk for cancer for a lifetime exposure of 1 sievert. And what that correlates with in our procedures, I'm going to show you in just a moment. That is why the ALARA principle guides all healthcare providers that use ionizing radiation, which is ALARA, as low as reasonably achievable. So you should always attempt to minimize the amount of ionizing radiation that you expose your patient to. Now, there's no question that if we compare our procedures to maybe far more invasive procedures, surgery, for example, well then, yes, it is an acceptable trade-off. However, I think it has become trivialized, and we need to be made more aware of the impact of ionizing radiation. Now, that's an alphabet soup here. We hear the term Röntgen and rad. So Röntgen is just what's in the air. Rads are what is radiation that's absorbed in tissue. But what is key is REM, and it's measured in sieverts, is the biological impact on tissue. And every tissue has a different response, a different sensitivity to ionizing radiation. That's the effective dose. So the effective dose, for example, for a chest X-ray is 0.1 millisievert. For an abdominal flat plate, it's 7-fold higher, 0.7. And that's because the abdominal organs are more sensitive to radiation. A chest CT is 7 millisieverts. Abdominal CT is 10 millisieverts. Now, I mentioned before, a 10% increased risk for cancer for 1 sievert over a lifetime. That equates to 100 abdominal CTs. Now you may think 100 CTs, that's a lot of CTs, but think about it. Let's say over 50 years, that is equivalent to 2 CTs per year. And we just heard from Manu that some of the patients that undergo drainage of wands have a mean of 14 CTs. If we compare now CT to ERCP, so as mentioned, abdominal CT, 10 millisieverts. A diagnostic ERCP, on average, delivers 7 millisieverts. A PET CT, which of course involves more radiation, is 14 millisieverts. Therapeutic ERCP, as soon as we're extracting stones or putting a stent in, 12 millisieverts. Multiphasic CT, 30 millisieverts for every 20 minutes of fluoroscopy that we use, and that's why it's important to time your fluoroscopy, 20 millisieverts. Now, these are the 3 metrics that are listed in every radiology report. It's a requirement by law in the United States. So it's the dose in gray, and then the dose area product, that's called the DAP, and then there's the fluoro time. Now, from a practical standpoint, all you need to remember is the fluoro time, because the fluoro time has been shown to correlate directly, as you can see here, linearly with the DAP, the dose area product. But all three of these metrics are measured on every radiology report, every CT report. In fact, yesterday I did take some snapshots of some of our more complex procedures, the HGS. So the mean time was about 15 minutes, fluoroscopy time, and the mean dose in milligray was 150. Now we know that the fluoroscopy duration during ERCP is a critical determinant of the amount of radiation exposure. So as soon as you're putting a guide wire in, you're doubling the radiation exposure. If you use a balloon catheter, it's 4-fold increased. If you do lithotripsy, 4-fold increase. And if you do stenting, a 3-fold increase. So as soon as you're doing these interventions, and sometimes there are multiple of these, right? So you are multiplying your fluoroscopy time. And that is why the ASGE is now emphasizing best practices to reduce, to limit the time, the fluoroscopy time when we do ERCP. And you might take a look at some of these. You avoid unnecessary panning, moving around with the fluoro on. You should use intermittent taps of the fluoroscopy pedal. It should be pulsed, not continuous. Yesterday I observed a lot of it was just continuous on the pedal the entire time. You should use last image hold. Avoid unnecessary spot films. We used to have to take dozens of spot films because the radiologists read our reports. That's no longer required. We can bill for those ourselves, but it's an opportunity to minimize the number of spot films. And pay attention to the fluoroscopy time. Use a 5-minute timer to limit it. So now let's transition over to EUS-guided non-radiation ERCP. And I'd like to share with you really where this journey started for me. Personally, I was a fellow at Oregon Health Science University, my mentor, Ron Caton. So this was one of our ERCPs, 27-year-old female, 10 weeks pregnant with severe abdominal pain, high white count, bilirubin 2.3, elevated amylase. I saw the patient before her ERCP. She was very sick, in a lot of pain. We got a transabdominal ultrasound. There was no EUS back then. And the CBD was dilated to over 2 centimeters. And there was a stone visualized in the distal common bile duct. There you see it. You might think this is an EUS. It's a transabdominal ultrasound. But I think back at that time, they were done by radiologists, and they were done very well. Well, when the patient came to us, there was this bulging papilla. I did a pre-cut. It was my very first. The stone literally popped out, and pus followed, and the patient instantaneously was cured with no radiation. That case impressed me so much that I was then determined, when I had the opportunity to learn endoscopic ultrasound, to go to Hamburg, Germany, to spend time there. You see, diagnostic EUS, if you routinely perform that before an ERCP, it has been shown in multiple randomized controlled trials that it can avoid an unnecessary ERCP in up to 2/3 of patients. Now, that's all comers. In our personal experience, and I'll show you some of that data for patients referred with stones, if you do an EUS before your ERCP, you will avoid the need for ERCP in 30 to 40% of the patients. And of course, it significantly reduced overall complications, obviously pancreatitis being the main one. But that diagnostic EUS before ERCP gives you important information about the etiology of obstruction, whether it's truly a stone or maybe a tumor. If it's intraductal, like here, or if it's extraductal with extrinsic compression. So you're already saving time during your ERCP. Even if we say we only do therapeutic ERCP, the reality is we're spending a lot of time with fluoroscopy doing diagnosis, We can eliminate that with EUS. Now I want to show you this, and this is not that once-in-a-lifetime case. This is routine for me. It's just a bit dated because you can see it's a radial scanning echo endoscope. You see 3 stones. You can count them, 1, 2, 3. Followed now by the ERCP with the sphincterotomy. You see it now. And then after the sphincterotomy, I pass a basket. I like to use the Dormia basket. And I extract the stones, and I'm watching and counting the stones as I remove them. And so here you see there was number 1. Now comes number 2. And I know there are only 3. So I have 1 more to go. So I pass the basket up a 3rd time, and we have our 3 stones. So we're able to correlate what we saw on EUS precisely with what we see on, quote, ERCP, but we actually haven't used any fluoroscopy. So it really isn't a cholangiopancreatography, it's a endoscopic retrograde intervention in ERI. Another example, a more recent one, using the linear array, which we now pretty much are exclusively using. So you can see in the distal bile duct, here's a stone, measure it, it's a single one, measure it precisely out at 1.2 centimeters, and cannulate. I like to use the ultra tapered tip with a 4 French tapered tip because it slides more easily in to the duct. Aspirate. If you get bile back, you know you're in the bile duct. If it's clear, then you reorient and recannulate. You never inject contrast because we're trying to avoid using any radiation. So you do the sphincterotomy now. You see the gush of bile, so you know that your sphincterotomy was adequate. So your sphincterotomy should always be tailored to the objective of your procedure. So when you see the bile gushing out, and we already saw that the stone is only 1.2 centimeters, so we don't have to make a 2-centimeter cut. And then we trawl with an open basket. So it's a different technique than the way the basket was originally designed, which is to grab the stone and pull it out. Here we're using the basket like a net, and we hold it open at the ampulla to draw the stone and the bile into the basket. So I call that the open basket at ampulla technique. We straddle the open basket across the post-sphincterotomy ampulla. We apply suction to draw the fluid along with the stone into the basket. This basket acts as a net to catch the stone. Where did I learn this? I learned that from Nib Sahendra, and I have him to thank for this technique that I have used ever since I started using it in Hamburg. I like to do this flush to gush. I advance the basket 8 to 10 centimeters. That's essentially the distance between the ampulla and the hilum. I open the basket 20%, and then I flush with saline until I see clear fluid. And this is what it looks like. So here, rapid flushing with the basket open 20%. And you can start to see the fluid, but I keep flushing, or say the assistant is flushing vigorously until I see completely clear fluid coming out. Sometimes in the beginning there's a lot of sludge, and I'll keep irrigating vigorously until the contents are completely clear. That's how I'm able to confirm that the duct is stone-free. Obviously, you could put a cholangioscope up there, you can put a mini probe, all these things are also doable. Now, this is an example where EUS, just with one image, I'm not even going to show you the video because it's obvious. There's the shadowing, there's the stone, it's impacted at the ampulla, and here's the dilated bile duct upstream. The rest of the bile duct was normal. So this is where I proceed immediately to a pre-cut. I'm not even going to try to cannulate the bile duct because I know the pathology is the stone impacted at the ampulla. So I actually start above the papilla. I avoid the pancreatic duct completely. This patient has 0 risk of pancreatitis after this procedure. And now I very carefully dissect open, and there you can already see the stone. and then I coax it out. You can see how now the stone pops out. So it's up to you. You could, finish this with a standard sphincterotomy, but it's probably not necessary because you can see now the bile draining. So this is really an adequate procedure. You can stop there. So I published back in 2013 on a non-radiation ERCP in pregnancy. So this is again continuing my journey and my obsession with avoiding radiation. And obviously there's a strong indication for that in pregnant patients. And again, there's that 40%. 4 out of 10 had no stone. So I was able to avoid ERCP completely in those patients. The 6 who had non-radiation ERCPs, I did do cholangioscopy in 2. There were no adverse events. And this is, I've just compiled for DDW, so we'll be presenting this next year in San Diego at DDW. But this is an accumulation over 5 years, 397 patients with suspected CBD stones, referred for ERCP. Now 120 of these, there's that 30%, had no sign of a stone. So we avoided ERCP altogether. So ERCP was unnecessary in 1/3 of these patients. And then there were some patients that needed radiation for whatever reason. And of course, I have my colleagues working with me that may need to tap on the fluoro. So I wanted to exclude those patients, even though the radiation was minimal. And so we have 170 patients who had pure, non-radiation, EUS-based ERCP. In other words, these are patients you don't even need to do with X-ray equipment. You can do it in a non-fluoroscopy room where you do your colonoscopies. And here are our outcomes. Technical success, nearly 100%. Clinical success, nearly 100%. We had post-ERCP pancreatitis rate of 2.4%, so very low. And our recurrence rate was 2.4%. And these are 4 patients that had recurrence. And we followed these patients now several years. And 2 of those patients actually had the gallbladder in situ and refused to have cholecystectomy. So I wonder whether it was just a gallbladder stone that then migrated later into the bile duct. And in the other 2 patients, well, one of these patients actually had a history of recurrent pyogenic cholangitis. And the other patient had a distal CBD stricture that needed to be dilated. Now this is a study, it's a randomized trial, so it did catch my attention. I actually wrote an editorial to this when it appeared in 2017. Now even though they call this EUS-assisted ERCP without fluoroscopy, the truth is they did use some fluoroscopy. So you can see the mean no fluoral 3.2 versus ERCP group 5. Now it was significantly different between the groups, but it's not purely non-radiation. But it was able to show that their cannulation success was very, very high without having to use fluoroscopy. Stone removal rates were very high, although there was a difference between the 2 groups. What is important is to pay attention always in these studies to the methods. So they cannulated with a guide wire. They did a balloon sweep over a guide wire. And to confirm that there were no stones, they did use some fluoroscopy. So it's really a very different technique from the one that I use. And now we're going to end with the best, always comes last, ductoscopy-guided non-radiation ERCP. And this is, I think, where in the next years we're just going to see an explosion of new technology. We are all familiar with finger-operated ductoscopy. It's been around a long time. Yes, there have been some incremental improvements in the optics, but no real major advancements. And we limited its use, in part because of the high expense, to indeterminate strictures, refractory stones requiring lithotripsy, and maybe in those refractory strictures we couldn't get a guide wire through, so we introduced our cholangioscope to help guide that wire across the stricture. But then we have this study, and this is down the road from me and at Stanford, where they did a prospective evaluation of radiation-free direct solitary cholangioscopy for the management of colodoculithiasis. all comers really in this study, 40 patients, and they were successful in 100% of the patients, not using any radiation at all, and using cholangioscopy in all of these patients. Their clearance rate excellent and a low adverse event rate. But you can see again here, biliary cannulation without fluoroscopy using bile aspiration as the indicator whether you had successfully cannulated the bile duct. Then proceeding to sphincterotomy, then introducing the cholangioscope and determining the size and number of stones with cholangioscopy, and then extracting those stones, and they used mostly a balloon. So a bit of a different technique. Now they have updated their experience in this cohort of 47 patients, a multi-center trial, but using the same technique, the same algorithm, and their success rate, again, very, very high without using any radiation, 89%. Some failed cannulation that required fluoroscopy, clearance rates of 83%, low adverse event rate. And this is a study from China, sort of maybe the only place where you can really start to get aggressive and do things that are more radical. And they're using cholangioscopy guided ERCP for all comers for stones in this study, where they're also going into the intrahepatic ducts. Now they're benefiting from cholangioscopes that are only available, or ductoscopes, in China, which much smaller diameter. Now we will benefit in the future from these. Going into the cystic duct, the gallbladder, and a very low adverse event rates. But you can see here the various modalities that they're using, all cholangioscopy guided. What we're seeing is ductoscopy in evolution. We have significant ductoscope enhancements. We have ductoscopes now that have a diameter of 7 French. We'll be seeing these very soon, and maybe even smaller, with larger working channels. There's one already available now. Maybe it was even shown during the meeting with a 2mm channel. And the optics are stunning. Magnification, digital chromoscopy, and obviously AI, it will be added to this. But more importantly, the accessories that we can advance through the ductoscope. And I heard from Claudio today, there's even a mini probe that can be advanced through the ductoscope. That's exciting. So we're talking about extraction balloons and baskets, dilating balloons, all introduced under cholangioscopic guidance, and even stents. So I'm going to share a couple of very quick videos. This is the 7 French cholangioscope. It has a 0.8mm working channel. And here, if I can, oh, the video doesn't work, I'm sorry. Well, here you can see the cholangioscope has been advanced to the very end, or really it's the beginning, of the bile duct, of the intrahepatic bile duct. Look at it. It's right at the liver capsule. It's unbelievable. This has gone all the way to the very end. So there is no duct that cannot be explored. But what is really exciting, in my opinion, is the ability to place a stent. No different than the way we're now placing, for example, esophageal stents. I don't use any fluoroscopy when I place esophageal stents at all. It's all endoscopy guided. So with a 2.0mm channel ductoscope, we can place a stent under direct ductoscopic guidance. And here you can see one video from Robles Medrano, from Carlos in Ecuador. And he has many beautiful videos like this that you can find on the internet. But he very kindly shared this one with me. So you can see how he is deploying this all under direct cholangioscopic guidance. Now, he did use some fluoroscopy in order to prove that it was in good location, but there's no need for that. And you could theoretically pass your ductoscope through the stent just to confirm that the upper end of that stent. And I think this dovetails very nicely with what Max was talking about in his lecture. We want to minimize the amount of stent that is unnecessarily in contact with normal epithelium. That's where you get hyperplastic tissue reaction. You always get a foreign body reaction. So limit the length of your stent to the length of the pathology to your stricture. And here is an example of EUS-assisted cholangioscopy. So again, we're really getting into the hybrid idea here. Hopefully this video will work. There we go. So you can see we have placed an HGS, hepatogastric gastrostomy stent, and now through that stent we immediately place our advance our ductoscope. So we are combining now using essentially that stent as a port, kind of the idea of the LAMS as a port to extend the reach of endoscopy to spaces that we previously could not access. So this is a beautiful example of a hybrid procedure combining the placement of this stent with EUS. And finally, this really intrigued me. Maybe we even will be cannulating with the ductoscope. This is a 7 French ductoscope. It has a cap mounted on the tip. Now we all know how valuable a cap can be and how it allows us to get through strictures that otherwise may be very difficult to access. And here in this video, you can see how the intubate, the cannulation, is being done with the cholangioscope with this cap. And I think the cap is even a little tapered at the very tip. So now under direct endoscopic guidance, you can see those septae that often prevent you from getting access, and you can avoid those septae and get access to the bile duct. So that's really exciting. You know, we don't have to monkey around with wires constantly injecting contrast multiple times. We can just go directly under cholangioscopic or pancreascopic guidance. So will X-ray become extinct? Well, just look back. Where have we been? This is how we used to evaluate the upper GI tract. It's replaced with endoscopy. This is how we used to evaluate the colon with barium enemas. It's been replaced with colonoscopy. This is how we used to evaluate the small bowel with upper GI series, huge amounts of radiation for that. Now we do capsule endoscopy and double balloon enteroscopy. We've eliminated the need for fluoroscopy and X-rays. Well, I think it's just a matter of time. The writing is on the wall. We will replace fluoroscopy, radiation exposure, with ductoscopy. And in that editorial that I mentioned back in 2017, I wrote, an intentional strategy favoring EUS and ductoscopy in lieu of fluoroscopy will allow us to take the lead off in yet another domain of gastroenterologic intervention. And why is that taking the lead off itself of some practical impact for us who spend our days in our unit wearing that heavy lead hours on end? It takes a toll on our body, on our ligaments, on our tendons, and I personally have experienced that. So I think in the interest of improving ergonomics in endoscopy, a very important area, we need to find ways to take the lead off. Thank you. Thank you, thank you.